Good morning, dear colleagues online. So I'm Dr. Junjie Zhang. So today I'm really happy to have our Asian Cardiovascular Society Clinical Research Seminar. In the next 2 hours, this is struggle heart disease sessions. Today, there are three moderators. I'm Dr. Junjie Zhang from Nanjing First Hospital, and also another distinguished expert, Professor Wang Yan from Xiamen Cardiovascular Hospital, and Professor Zhu Da from Yunnan Fuwai Hospital. So first, let me introduce the first distinguished speaker, Professor Song Sixian. So Professor Song received the MD and the PhD degree from the National Yangming University, Taiwan in 2001 and 2014. He has been the faculty of the Department of the Medicine, National Yangming University since 2019, where he is a current professor. He completed internal medicine residence training and cardiology fellow training at the Taipei Veterans General Hospital in 2009, where he is currently attending physician. He studied abroad for molecular biology in Fukuoka and Japan, and echocardiography research in Hong Kong, and transcatheter valve intervention in Mainz, Germany. His research interesting focus on cardiovascular hemodynamic, vascular aging and heart failure, and pulmonary artery hypertension. His clinical interest including heart failure care, transcatheter valve intervention, coronary intervention, and echocardiography. Professor Song Sixian is an expert, I think, not in Asia, but in the globally. So let me welcome Professor Song. It's your turn.
Thank you, Professor Zhang, for the kind introduction. And it's my pleasure to join this Great Wall International Cardiology Congress. And to present the first topic today will be the optimizing TEER through the comprehensive hemodynamic assessment. So this is my disclosure. I think we all know the acute hemodynamic change after mitral TEER. So this is the early data presenting the acute hemodynamic effect of mitral after the procedure. So on the right-hand side, the table showing that after the procedure, the cardiac output along with the systolic blood pressure increase, while the left ventricular and diastolic pressure decreases. And the systemic vascular resistance drops, but the pulmonary capillary wedge pressure and also mean pulmonary artery pressure remain unchanged immediately. We know that might be decreased thereafter. This showing that the TEER effectively unloads left heart and improve the forward flow without significantly affecting the right heart pressure. So what about the difference between DMR and also the functional MR? This is also a paper compare the acute hemodynamic change after mitral TEER. So the we can on the data on the table we can see that both groups experience increase in cardiac output and forward stroke volume. The left atrium pressure and also V-wave decrease in both, but the reduction is more prominent in DMR patient. In contrast, FMR patients show less decline in left ventricular and diastolic pressure, and these differences suggest that the underlying etiology of MR may influence the acute physiologic response to TEER, which should guide the individual procedure goal. So the data this study published in Circulation in 2013 used direct LV pressure volume loop recording to observe the immediate physiologic impact of mitral clip. In the majority of the patient on the right-hand side, you may appreciate that the end diastolic pressure would decrease predominant in patient with DMR patient, indicated by the black line, and also majority of patient, almost both DMR and FMR patient would have decrease in wedge pressure. On the left-hand side, showing the PV loop, which significantly demonstrated a shift increase in in left ventricular end systolic volume because increase in afterload. So on the right bottom figure showing that even the increase in end systolic worst rates, the cardiac remain, it would have no significant increase correlation with the increase in end systolic worst rates. This is the increase in end systolic worst rate is because the increase in afterload. We know that after TIA procedure, when we close the mitral, when we abolish the MR, the patient, the LV would face on the aortic pressure. So their significant would increase in end systolic pressure. So we see the worst rates would also be increased. But however, we see that after procedure, the patient would have persistent, consistent increase in cardiac output. But on the right, the figure B on the bottom right figure showing that the end diastolic worst rates would decrease because we abolish the MR. So we can observe the decrease in pulmonary capillary wedge pressure. So what about we know that there will be shift increase in end systolic volume. So basically, the patient would have decreased LV ejection fraction. So what is about the impact of immediately decrease in LV ejection fraction after mitral TIA procedure? So this is the data from the mitral ocean registration. Over 2,000 patients underwent TIA procedure. About 1/3 of them would experience worsening ejection fraction, defined as a relative drop in LV ejection fraction by 12.9% in LV ejection fraction. However, the higher the predictor of immediate worsening LV ejection fraction includes the higher baseline ejection fraction and larger LV volume, and also the presence aortic regurgitation. Importantly, this decline was not associated with worse clinical outcome. This suggests that the worsening EF ejection fraction may represent a physiological remodeling process rather than a true deterioration. So we all know that after the procedure, especially in patients with functional MR, we usually observe a decrease in LV ejection fraction, but which is not really related to the worst outcome, but may indicate a remodeling process. So this slide summarizes a study published in JAHA in 2018 that analyzed 130 patients who underwent successful TIA procedure, with majority of them have functional MR. They also used the echocardiographic data to non-invasively estimate pressure volume loop parameters before and after procedure. So on the left-hand side, on the right-hand side, patient with left ventricular ejection fraction less than 40%. We know that those patients with heart rate demonstrate limited change in end systolic pulmonary vascular volume relationship, ESPVR, and relatively stable stroke volume comparing in the follow-up and also comparing to immediate after the procedure. And these patients typically have a stiff, non-compliant left ventricle, and even after regurgitation volume is corrected, their ability to increase the full output is constrained by diastolic dysfunction. But on the left-hand side, in patients with LV ejection fraction over 40%, showed more significant shift in both ESPVR and also EDPVR. This indicates greater improvement in contractile function and also volume accommodation after reduction of the mitral regurgitation. The ventricular mechanism in this group allow for more favorable reverse remodeling. So when we treat patient earlier, the patient may get more chance to reverse the left ventricular geometry. So if we stratify the patient by the NT-proBNP, indicating that more severe tertile NT-proBNP, indicating patient from more severe LV dysfunction in patient with high NT-proBNP. So you may appreciate that the left ventricular ejection fraction in this population with majority of functional MR will remain the same comparing to baseline and also 6 months after procedure. Also, we understand those patients may have immediate worsening LV ejection fraction, but later on they will get recovery, but they did not really have improvement in LV ejection fraction. But when we looking into the LV global longitudinal strength, which indicate the LV contractility, showing that patient with high NT-proBNP would get worse global longitudinal strength. So basically, if patient has too severe heart failure, they might not really get reverse remodeling or the reverse the contractility of the left ventricle. But on the right-hand side, we see the LA volume would improve. Also, that is related to the reduce the regurgitation volume. And also the patient with high NT-proBNP level probably would have further increase in NT-proBNP level because increase the afterload. So this indicates that patient who has the worst LV function might not able to accommodate the afterload mismatch phenomena after the procedure. However, on the bottom right, showing that even the patient with very severe heart failure indicated by high NT-proBNP level, they all would have experienced improvement in functional class. So we know, so we don't, so this population might not really experience reverse remodeling, but they still can get clinical benefit in reducing the clinical symptoms. So what do we have any marker or indicator suggesting that patient will have long-term outcome even in patient with worse LV function? So this is data published from Cedars-Sinai. With 60% of them have functional MR. They define a patient with increased stroke volume. So they do the Swan counts and to have immediate evaluation of the forward stroke volume. If the patient have forward stroke volume, increase in forward stroke volume by 9%, which is referred to responders. So on the top left figure showing that if a patient can have immediate increase in forward stroke volume, those patients would have a better long-term survival. And also on the right-hand side showing that if the patient, the responder would also have progressively reverse remodeling in left ventricular end diastolic volume and also left ventricular end systolic volume. So basically, if the patient can have acute response in increased forward stroke volume, those patients would probably have higher chance to get LV reverse remodeling. On the bottom left, showing that even the patient are not responders, they can also benefit in improvement of the clinical symptoms. Both of them, or both of the two groups, would have improvement in clinical symptoms. So we still can, if we want to pursue LV remodeling, we have to treat patient earlier. So is there any other indicator suggesting in patient will have more favorable outcome? So this is also what we can have during the procedure. We can measure the cardiac index, we can understand the wedge pressure, we can measure the V-wave. So basically on the right-hand side showing that the decrease of wedge pressure, the V-wave actually have similar performance as the decrease in wedge pressure, and also mean pulmonary artery pressure can predict a long-term outcome. So during the procedure is quite simple. We just need to, we are able to measure the V-wave change during the procedure. So the change can really predict the long-term outcome. So that is during the procedure, we can measure that. And as well as the LA mean pressure can also predict the outcome. This is the data from Swayson, from Maseno, showing that if the patient can have immediate decrease in LA mean pressure or LA mean pressure index, which showing that the patient will have long-term better clinical outcome. This is very useful while we are doing the mitral TEER. We know when we would have patient with residual 1+ or 1 to 2+ MR, and also we are considering to have additional clip to further abolish MR, but somehow the patient might get increase in LA pressure due to the loss of mitral valve opening area. So the pressure indicator, the pressure, pulmonary left atrium pressure, can give us some guidance to consider further clipping or to leave the patient with a 2+ MR. So this is all showing that after the procedure, the acute change in VWAV are really associated with the clinical symptom improvement. On the left-hand side, if the patient can VWAV significant improvement, and also the LA wave pressure improvement, those patients can get really improvement in 6-minute walk distance. So we can have a guidance from during the procedure on the VWAV. And each millimeter mercury decrease in mean LA pressure would have 90% increased likelihood of post-procedure class 1 symptoms. So basically, if you can pursue VUF the reduction after procedure, majority of the patient would have even functional class 1 symptoms. I think that is what our treatment target. Not only we actually treat the patient symptoms, but we also pursue the LV reverse remodeling. But given that not really every patient can get LV reverse remodeling, but if we can focus on the pressure indicator, we can also to abolish all the symptoms of the patient. So is there any other indicator to guide our procedure related to have intra-procedural guidance by the not only the hemodynamic but also the echo can show in the relationship with the long-term outcome. So this is showing that we know that the residual MR more than mild, or the transmitral valve gradient increase, and also the pulmonary flow reverse flow feeding a pattern normalization, which means that abolish the systolic reversal. Those indicators are good, correlated with the long-term outcome. So not only the residual MR, but also the pressure gradient. So although the updated evidence showing that the patient might able to tolerate higher mean pulmonary artery pressure, but this is the two patients with, if the patient have TMPG over 5, they are still potentially have worsening long-term outcome. So during the procedure, we are not only pursue 1+ or 0 MR, but we need also to focus to pay attention on the mitral valve pressure gradient in related to the pulmonary artery left atrium pressure. So this is the left atrium pressure showing that the data showing that it's the left atrium pressure, but not really the transmitral mean pressure gradient correlated to outcome. So this is not really mean pressure, but the mean pulmonary pressure gradient correlate with the left atrium pressure. So this is also showing that if the patient can have decrease in LA pressure, those patients will have improvement in long-term clinical outcome. So the hemodynamic effect of mitral TIA in patient with end-stage heart failure, also those patients might not able to have significant reverse remodeling. But those patients, if we can decrease the systolic pulmonary ratio, decrease the left atrium pressure, those patients can still have better long-term survival. So this is the acute change in patient with end-stage heart failure in transplantation list, showing that after mitral clip procedure, we can see the improvement in SVO2, which indicate the cardiac output. On the bottom left, we're showing that the patient will have somehow decrease in wedge pressure, but not significant. On the bottom right, showing that the patient may have decrease in systolic pulmonary artery pressure, mean pulmonary artery pressure. So we still can have hemodynamic improvement in patient, even in patient with end-stage heart failure. So we know that the residual MR is not a good more than moderate MR may not may bring patient with worse clinical outcome. But we also know that the mean pulmonary artery pressure gradient nowadays might not really impact on the left side. So during the procedure, how can we judge whether or not we need to put more clips? This is the data from Matsuson showing that they stratified the patient into 3 groups. The group 1 would be the optimal group hemodynamic, which after procedure, those patients have residual MR equal or less than 1+, and also mean LA pressure equal or less than 15 mmHg. If a patient have either residual MR more than 1+, or the mean LA pressure more than 15, would be classified as group 2. And in group 3, which indicates that patient with not only have residual MR more than 1+, but also have mean LA pressure more than 15. The long-term survival showing that the patient with optimized hemodynamic would have the best long-term survival. So if the patient have the poor hemodynamic, which means that not only have residual MR more than 1, but also mean LA pressure more than 50. So what are the determinants of mean LA pressure? On the bottom right table showing that the mean pressure, also the mean pressure grade did not correlate to the outcome, but which showing that the mean gradient might correlate with LA pressure, mean LA pressure. So basically, it's the mean LA pressure correlated to the outcome. So during the procedure, we can have indicator when we try to further clip the patient to abolish 2+ MR to less than 1+, or even 1+ MR to 0. We can also measure the LA pressure. If the LA pressure went high, maybe that would not be an idea. So if the mean pressure gradient went over 5 or even over 5 mmHg, if the decreased MR can also bring, if we can decrease MR as well as the LA pressure, we don't need to hesitate to put another clip. So again, the hemodynamic significant improvement is also related to the hemodynamic pattern. So if the patient can have a decreased LA pressure and also the residual MR, those patients would have most improvement in functional class. So again, this is data from the other center showing that the LA pressure is a predictor of long-term survival. But the determinant of LA pressure, the mean pressure gradient, is one of the determinants of LA pressure. So the mean pressure gradient might not directly related to the outcome, but it is the determinant of the baseline of the LA pressure. So we can assess the LA pressure rather than if we have conflict about the residual MR and also mean pressure gradient, we can have another pressure indicator, which is LA pressure, to guide our procedure. So this is the recent publication from Ocean Mitral registration showing that we all know that patients with severe MR might also have concomitant tricuspid resuscitation. So this is data stratified by after procedure, during the follow-up, if the patient have new onset TR or if the patient have residual TR. We know if the patient have new onset TR or residual TR, we have worse clinical outcome. But the determinant of the progressive TR or the residual TR is correlated with post-procedure mean pressure gradient. On the left-hand side, which will be pulmonary artery wedge pressure. So we know after procedure, we need to, for patient, especially for patient with severe MR, we have to make sure that if we leave higher mean pressure gradient, we need to check LA pressure gradient. Or in those patients who do not have TR at baseline, but because increase in mean pulmonary artery pressure gradient, the patient might have increase in pulmonary artery pressure and then have new onset TR. So I think basically although we know that the mean gradient might not impact on the outcome, but the left atrium pressure gradient it is. So nowadays we know that we have more indicator to guide our procedure during the mitral tear. So although mitral tear induced the hemodynamic unloading in patients with severe MR, cardiac reverse remodeling is not consistent observed. And universally, we may observe an increase in cardiac output and a decrease in LA pressure, especially the V wave, when severe MR is abolished. The suboptimal improvement in LA pressure might offset the efficacy of mitral tear while pursuing less MR, with a consequence of greater post-tear mean pressure gradient. And redefine the procedural success for mitral tear. Nowadays, we know that 2+ is not enough, so we pursue residual MR equal less than 1+. And also, basically, we need the post-tear mitral mean gradient less than 5. But if we have conflict residual TR, when we have conflict, we can check LA pressure. If the LA pressure remains low, we don't need to hesitate to put an additional clip. But if the patient already have increase in LA pressure, we probably need to consider to leave 2+ MR, but less mean pressure gradient. So thank you for listening. Thank you.
Thank you very much, Professor Siqian. So excellent presentation about how to optimize the TEER procedure for MI through the comprehensive anatomic, also including echo assessment. So I think TEER procedure is now used for FMR or DMR with heart failures. According to your presentation, actually we should pursue to not only reduce a regular MR less than 1+, but we should also pursue avoiding increase of LA pressure like more than 15 millimeter mercury. So I think now we can open discussion. So our distinguished panelists, is there any question or comment to Professor Siqian?
Prof. Song, can you hear me?
Yes.
Excellent presentation, learn a lot. Thank you. And I have two questions. One is about the deterioration of airway function or airway function after TEER procedure. You mentioned that the EF is a predictor for the deterioration. Maybe because of the, I think it can be described as afterload mismatch. Is that right? So you mentioned the EF is a predictor, but as we all know, the low airway EF is a predictor for the after mismatch after TEER. But I see in your lecture you mentioned higher EF. So how to explain this? Maybe I just understand there's a higher EF, the lower decrease after TEER. Is that right? This is my first question. The second question is also about the decrease the airway function after TEER. I think one reason is afterload mismatch. But have you concern about or encounter about the stress-induced cardiomyopathy? Yeah. So just days before we encounter for one of patient after the TEER airway function reduced and the coronary artery is normal and the airway function before the TEER is definitely normal, but after the procedure we can see the almost the whole of the left ventricle apical aneurysm. So we just diagnosis this patient is stress-induced cardiomyopathy. Is that suitable? Yeah, and for these patients, kind of patients of therapy. Thank you, Professor. Yeah.
Yes, I think these two questions are very important. That in the mitral ocean registry, showing that the higher baseline LV ejection fraction is a predictor of immediate worsening LV ejection fraction after TEER. It is because related to the hyperdynamic of left ventricle. If the patient have torrential MR, if the patient have very severe MR, the patient may have pseudo increase in LV ejection fraction. So that is the reason in the mitral ocean registry. And the other question is about the immediate afterload mismatch. We know that the patient have very poor LV ejection fraction from the PV loop data showing that all of the patient have increase in LV end systolic volume and also increase in LV end systolic wall stress, which means that immediately after the procedure, basically due to afterload mismatch, due to the increase in afterload, the LV would encounter very significant increase in afterload. So therefore, we saw that a patient with high NT-proBNP level after procedure, they may have even further increase in NT-proBNP because of wall stress. So the only if the patient had baseline, but majority of the patient will have increase in stroke volume. So somehow, but if the patient have really depressed LV function, I think the most important, worthy procedure will be put on the mechanical support for couple of days. I think within days, maybe within in our experience, within 48 hours, if the baseline, if the patient can get rid of the low cardiac syndrome after the procedure. We know the low cardiac syndrome in surgeon's view is quite common after the surgery, but in the transcatheter therapy, which is much less, but still, if we have very severe depressed LV ejection fraction before the procedure, the patient still would encounter low cardiac syndrome after the procedure. So those patients need mechanical support. And that's it from our view.
Thank you.
Okay, is there any comment or question from our
I have
panelists?
a short questions, Dr. Shu. As we know, so many hypertension, pulmonary hypertensions, in maybe more the PSP more than 13, including excluding the contrast. But in reality, we do this kind of patients, but it's also a high risk. So sometimes the PSP below decrease maybe indicates a poor prognosis. So what kind of pH, maybe CBC pH or IPCPS indicate a more poor prognosis as your experience?
I think according to our experience, we know that if the patient with isolated postcapsular pulmonary hypertension related to the mitral regurgitation, those patients will really get very quick improvement, and also the symptom will abolish after the procedure. But for patients with combined pre and postcapsular pulmonary hypertension, those patients might already have very long persistent heart failure process. The patient already have heart failure for a long time, so the patient already have pulmonary vascular remodeling, or the patient might also have concomitant pulmonary disease, the lung disease, which can also increase the precapillary vascular resistance. So for those patients, those may not really get totally symptom-free after procedure, but those patients still can get improvement in their clinical symptom and also the cardiac output. So we also from the PV is showing that even increasing wall stress and systolic wall stress, the cardiac output consistent improvement after procedure. So we know the procedure can really increase cardiac output. I believe that if we can increase cardiac output, every patient can get improvement after the procedure. But if the patient have isolated precapillary pulmonary the precapillary pulmonary hypertension, which means that patient have pulmonary vascular disease, those patients might not, I don't know, those patients whether or not they can get improvement after the procedure. So if the patient have significant V wave, we know the data, significant V wave, pulmonary vascular reverse remodeling, feeding flow pattern, and also I think those patients can get improvement, either in some in some degree, may not be totally abolished, but still can get benefit. So That is why we showing that even patient at EF less than 40, very high anti-protein level, they still can get improvement in clinical symptoms. So
Okay, thank you. Thank you.
Okay, thank you very much, Professor Sixian. So let's go forward. So Professor Zhu Da, please host the next presenter, Dr. Zhang Juan.
Okay. So thank you for the audience, and we are moving to the next section. So the title was MTL for papillary muscle rupture after acute MI. It's a very interesting emergency condition for TIA procedures. And then the presenter will be Professor Zhang Juan and from Nanjing First Hospital. Okay, I make a brief introduction to the speakers. Professor Zhang was Deputy Chief Physician of the Department of Cardiology, Nanjing First Hospital, and he's a standing committee of Nanjing Association of Preventive Medicine Coronary Non-Communicable Disease Prevention and Treatment Professional Committee. And he's specializing in structural heart disease, especially on structural heart imaging, and perform a lot of TIA procedure and mitral and tricuspid TIA procedures. And he's a member of Chinese Heart Failure Professor Committees. And that's now we welcome Professor Zhang and presenting his lectures.
Thank you, Prof. Zhu. Thank you for your introducing, and thank you for Chief. So let me to share my. Oh, okay. Can you see my screen, Prof?
Yeah, of course.
Okay,
Yeah,
thank you. Good morning, Chief. Good morning, dear experts and colleagues online. It's my great honor to represent our Professor Zhang Junjie, Nanjing First Hospital, to share our experience in treating severe mitral regurgitation caused by papillary muscle rupture. We call this PMR with TIA in our cardiac center. PMR is one of the fatal complications of AMI. Patients with this condition usually have a sudden onset and are often in a critical state, making the rescue efforts highly.
Your PPT is frozen, so can you share again and also full screen your presentation?
Okay.
Still not full screen. Yeah.
Here again. Okay. Thank you. I'm sorry. Yeah. So the critical state making rescue efforts highly challenging. So first, let us start with our case. So actually, this is a 37 years old male complained for chest pain for 1 hour. ECG shows ST segment elevation in these 2, 3, and AVF. All this indicated the patient have acute myocardial infarction of the inferior wall. So the emergency angiography shows criminal vessel is middle RCA, almost totally stenosis. And after returning to the ward, after emergency PCI, the patient had acute left heart failure and cardiogenetic pulmonary edema occurred suddenly. So the patient was transferred to the ICU for intubation. And because of the cardiogenetic shock, so the IBP plus ECMO were used to assist the circulation. So the bedside TEE verifies the acute rupture of the posterior papillary muscle with torrential MI. So the patient just to a statutory for the emergency TIA. So this is angiography for this patient. For here, we can see, although there is severe stenosis in LAD, the RCA is criminal vessel. The almost totally accruement of the middle RCA. So after the emergency PCI, drug-eluted stent was deployed in the mid RCA. So the RCA fluent was recovery, and the TIMI flow grade was 3. So during the TEE for the TEER procedure. So here we can just find out the completely papillary muscle rupture of the posterior commissural muscle. So here we can see the muscle just flow up to the LA and fly very high. So the full chamber view, bicommissural view, and the left ventricular outflow tract views. So here we can notice the prolapse of the posterior medial commissural and the complete rupture of the muscle, resulting mitral regurgitation is torrential and the hemodynamic compromise. So the 3D TEE also show us vividly the complete rupture of the posterior medial papillary muscles with torrential MR. Here we can see the muscle and the tips and the leaflets fly very high to the LA. So this is a TEE during the TEER. So the height of the atrial septal puncture is about 4.5 centimeters. So it is, I think it is acceptable, although the LA is not so big. So it's not so dilated. So the first clip was deployed with Mitral clip XTR. So with this clip, we just try our best to catch the flight muscle. Yeah. So here we just successfully catch the muscle and close it. So after the first clip was deployed, we can see immediately the MR, the torrential MR is improved. It's reduced to 1+ or 2+. So, and the mean pressure gradient is 4 millimeter mercuries. But we just check the TE. We still can find the residual mitral regurgitation and the residual prolapse or flare from both the lateral or medial side of the first clip. So I think the first clip, the function of the first clip is to catch the fly muscles and to lie down to the annular level. So the next step, we just put a second clip lateral to the first clip. Yeah. So after the second clip was deployed, the mitral regurgitation and the residual flare lateral to the first clip was, I think, treated. But there is still residual mitral regurgitation 1+ or residual flare segment medial to the first clip, and the mean pressure gradient is 5 millimeters mercury. So I think although the mean pressure gradient is 5 millimeter mercuries, but it is just stay in the state that there is residual 1+ MR. So if we put another, the third, clip, here we can see we just put a third clip medial to the first clip, and there is a very excellent good result. The mitral regurgitation almost diminished, and only 1+ MR residual, and the mean pressure gradient were not elevated. It's still 5 millimeter mercury. So there's an interesting phenomenon. I think Prof. Song discussed before. That is the deterioration of the left ventricular function during TEER that we call afterload mismatch. So actually, after the first clip was released, the patient experienced a difficult to correct drop in blood pressure. So TE revealed that the airway function was significantly weakened, and the aortic valve could not open, and there was a clear spontaneous echo contrast in the aortic root. So at this moment, we just judge that the patient has exhibited typical called afterload mismatch. Then we immediately administer the patient with intravenous infusion of dobutamine to enhance myocardial contractility and reduce the speed of ECMO to decrease the afterload. So here we can see after timely adjustment of the drug and the ECMO parameter settings, the patient's cardiogenetic shock was corrected, cardiac function improved, and the blood pressure returned to normal. So actually, what is afterload mismatch? Afterload mismatch in the context of mitral regurgitation refers to a situation where the left ventricular's ability to pump blood effectively is impaired after the correction of MR, either surgically or TEER. So this occurs because the reduced mitral regurgitation or the lack of blood back into the left atrium leads to an abrupt increase in the afterload, which the resistance ventricular face during contraction. This sudden increase in afterload can overwhelm the ventricular, particularly if it was already weakened by the chronic volume overload of MR, leading to a drop in ejection fraction and potentially heart failure. So we must pay very attention to the afterload mismatch in TEER for PMR. In case of acute decreased cardiac output, as we mentioned before, a positive inotropic agent should be added. Acute deterioration or progress to cardiac shock requires mechanical circulatory support. Yeah. So this imagines as a 3 months TTE follow-up after TEER for this patient. So from the views, from the apical lung views, from the apical four-chamber views, and the short axis views, we can all see the clips were stable, and the airway function definitely significantly improved, and the MR is still mild and 1+. Yeah. And after 3 months, the mean pressure gradient dropped to 3 millimeter mercury. So at this time, we do the scheduled PCI for this patient. So actually, the residual lesion of LAD was certified by DES deployed by IVER's guidance. So actually, this is a happy ending for our case. So as we look back to the mitral regurgitation after mitral infarction, actually in AMI, mitral regurgitation is almost frequent, followed by moderate and severe mitral regurgitation. Severe mitral regurgitation can reach 3% of patients. So even in patients undergoing primary MI, the severe MI is still in 1 to 2% of patients. So severe MI developing early after AMI is associated with decreased risks of heart failure and mortality. Among this, also, papillary muscle rupture, PMR, is uncommon with a prevalence around less than 1%, but the mortality rate has remained unchanged, very high for decades, up to about 42%. So although surgical treatment can improve survival, the incidence of adverse events and mortality remain high. So I think these pictures tell us the mechanics of acute mitral regurgitation after AMI. The picture A just shows us after myocardial infarction, tip papillary muscle rupture. Type B, figure B, shows us a complete papillary muscle rupture. And C is, I think C is not papillary muscle rupture, but functional mitral regurgitation phenotype with posterior wall leaflet restriction and local left ventricular remodeling. Yeah. So we will look to the papillary muscle rupture. So actually the posterior medial muscle is more frequently affected, caused by the anatomical vasculature of this muscle. So PMRs usually occur in the first week after AMI, more in the first 24 hours after initial presentation. So the papillary muscle rupture is more common in older women after inferior posterior MIs. But interestingly, with less extent of coronary disease and less diabetes. So actually, maybe PMI is a continuous spectrum that goes from papillary muscle elongation without rupture to rupture of tips or one of the heads of the papillary muscle and to complete papillary muscle rupture. So we can see the right videos. On the transgastric long axis view, the partial elongation of the continuity over the papillary muscle. The systolic elongation of papillary muscle creates an anterior leaflet prolapse with eccentric mitral regurgitation jet directs to the posterior left wall. So in the middle video, so from the bicommissure and the left ventricular outflow tract views, so we can notice the posterior leaflet flare with the small part of the papillary muscle. And on the right video, so the 3DT and PR show us the complete anterior lateral PMI, induced torrential MI, pulmonary edema, and blah, blah. So complete PMI induced torrential MI, pulmonary edema, and hyperdynamic collapse maybe need emergent interventions. But partial rupture may be better tolerated, allowing time to stabilize the patient and select the most, still have the time to select the most appropriate therapy. So this picture just is show us a clinical calcification for the available and the facilities consents within the heart team. So we just define the patients to four types. Type 1 is the most severe presentation leading to coronary shocks and pulmonary edema or even cardiac arrest. Type 2 includes patients with severe heart failure, pulmonary edema, but blood pressure is still okay. Type 3 represents a less severe form, characterized by episodes of pulmonary congestion and flash pulmonary edema. So we think the first three types will significantly affect patients' performance, which might warrant urgent intervention during the acute freeze. As to the type 4, includes patients with only mild to moderate symptoms of heart failure despite severe MR. So as to the medical management and the revascularization for these patients, so immediately coronary reperfusion is a cornerstone in the prevention and treatment of severe MR. Initially, medical management conclude the drugs used for release of pulmonary congestion with diuretic agents and drugs decrease afterload, reduce the regurgitation volume, or vasoactive support. But in case of low cardiac output, the positive inotropic agent should be added. So as we mentioned before, the most important is if acute deterioration or progression to coronary to cardiac shock, then requires mechanical circulatory support. So even up to 30% of cases with PMR. So actually, this is a waterfall flow for the treatment of severe MR after AMR. So revascularization is crucial for the treatment of severe MR. So this figure drives the regional and the therapeutic decision making according to clinical stability and surgical candidate. So it also involves the enrollment alternative for MCS for the mechanical support, even before or after surgery or TEER if needed. So we think IBP is still the first line of cardiocirculatory assistance in patients with acute MI post-MI. Because IBP can improve airway forward flow, reduce myocardial workload, increase coronary perfusion, and reduce airway and diastolic pressure. Therefore, IBP is still the first line recommended in the management of this kind of patients. However, if these patients frequently have a refractory cardiocirculatory collapse and severe anorgan hyperperfusion, making IBP assistance not sufficient. In these cases, more powerful mechanical support should be considered, for example, Impella CP or Impella 5.5. But for the more severe forms of cardiac shock, might require further upgrade of assistance with VA ECMO or tandem heart using a peripheral approach. So concomitant use of VA ECMO and Impella are recommended to spontaneous reduce airway filling pressure and improve cardiac output. So as to the surgical approach for the mitral, the surgical treatment for this kind of patient, there are choice of mitral valve replacement and mitral valve repair. So in the setting of acute MR caused by PMR, mortality rates with MVR remain very high. So the death without intervention, but although the risk for surgery is high, but the risk for waiting without intervention even higher, can reach prohibitively risk of 80%. So, and the mitral valve replacement with bioprosthesis is recommended for this kind of this patient. So the newly transcatheter interventions is we now recognize the ability to treat of this kind of these patients. So TEER treatment for this patient initially described as a case reports, and the largest series of PMI treated by TEER has recently represented. It contains 185 patients MR from 21 institutions in the United States and Europe. So here, so this study, we can find that the post-AMI significant MR is associated with poor outcomes. TEER is an emerging treatment option for this patient. So although this TEER for primary, for the papillary muscle rupture MR was conducted earlier than secondary MR with comparable procedural success. The procedure success is acceptable, but TEER in primary MR is associated with higher in-hospital mortality and higher conversion to open surgery over secondary MR. So this is our another three cases. One case is acute MR caused by partial papillary muscle rupture. Here, we can see the partial solution of continuity over the papillary muscle, and the systolic elongation of the papillary muscle creates anterior prolapse and severe MR. So the patient only accept IBP assistant, and one MetroClip XTR is enough to treat this patient. So after TEER, the MR was reduced to mild. And the second one here we can see is a rupture of the tip of the partially rupture of the papillary muscles. So the patient also can accept the procedure via only accept the IABP. So here we can see the posterior middle, the tips of the muscle rupture and the severe MR. So the final result is good. After TEER, the MR was reduced to mild. We used two measure clips, two XTR clips, and the mean pressure gradient is only 5 millimeter mercury, acceptable. And the last one is really, I think it is a really anterior lateral papillary muscle rupture. So here we can see the totally rupture of the anterior papillary muscle and the torrential MR. So the patient accept VA ECMO plus IBP. So the patient also gets the procedure successful, and after TEER, use two XTR measure clips. The torrential MR was treated and reduced only mild 1 plus, and the mean pressure gradient is only 4 millimeter mercury. So this is our experience in our center. So actually, our cardiac center successfully performed a total of 9 TEER for patients with PMR. All patients demonstrated favorable immediate post-TEER outcomes with significant variation of MR. So, but among the 9 patients, 3 cases resulted in in-hospital mortality. Further analysis revealed that these 3 patients were transferred to our hospital from other hospitals for TEER after acute myocardial infarction. The delay between the disease onset and transfer to our hospital, as well as subsequent TEER, was considerable, leading to severe compromised overall health conditions in these patients. Despite being supported by ECMO, in the case of acute MR, ECMO increased the afterload and failed to effectively improve the cardiac pulmonary circulation status. So I think the key experience we have driven from our treatment is that, given the minimally invasive nature of TEER, patients with PMR should be immediately considered for TEER follow diagnosis. Time is life. Transport the patient and perform TEER without hesitation, please. So concurrently, TEERs for there's a lot of potential advantages of TEER for pulmonary mitral rupture. So it is a new paradigm in the management of PMR, but still a lot of potential drawbacks of TEER. We just need a lot of try, and future randomized trials will further its optimal use. Yeah, thank you. Thank you. Thank you for your attention. Yeah.
Thank you, Dr. Zhang Juan, for your excellent presentation about TEER procedure for the papillary muscle rupture. So, Professor Zhu Da and Professor Si Xian and Chen Xiang, do you have some comment?
It's a very challenging conditions for TEER procedure. It's a mechanical complication of acute myocardial infarction. So now the literature has think this effect is very effective in treating this kind of extreme conditions. So, but actually, in China, due to the very limited experience, so a lot of intervention may be too late. I've encountered 2 patients, consultant patients, and he was already on ECMO and already multi-organ failure, and then we think to handle the acute mitral regurgitation. I think the early intervention is very important for this patient. So do not let the patient already on ECMO or multi-organ failure will be very optimal treatment strategy. This is my comment for it. And in some extreme conditions, for example, the severe rupture of a pulmonary muscles, even after tear, maybe in the very short period. So the MR should be recurrent. So the acute subsequent open heart surgical intervention may be necessary in some conditions. This is my comment. Thank you.
Thank you.
Yes, I think the PMR cheers is first is a very excellent presentations, and tier for the PMIs needs a very vast experience hard thing to do. Yes, just mentions by Dr. Judas need ECMO needs emergency PCI team. It's very wonderful work. And I have a small questions. Just what's the risks, as your experience, what's the risks of the resistance mitral stenosis in your data, and how to in your experience, how to balance the reduce MR and gradients?
So, Prof. Chen, your question is very good. Actually, your center has already done a lot of such kind of patients, and we ask for a lot of questions from you. You give us a lot of guidance for this kind of patients. So, we do nine patients totally till now of this kind. None of them we just got post-procedure stenosis. The maximum pressure gradient after is 5 millimeter mercury. As we mentioned for the first patient, the pressure gradient immediately after the pressure is about 5 millimeter mercury. But 3 months later, we just do the TTE for this patient. The mean pressure gradient dropped to only 3 millimeter mercury. Yeah. So, but actually, we should face this question. We should balance the stenosis and the microregurgitation reduction for this kind of this patient. But I think for this kind of patient, the problem of the acute MR to the pulmonary cardiac circulatory is the most important problem to the unstable hypodynamic of the patients. So I think mitral stenosis may be acceptable. Yeah, this is my opinion. So how about our Prof. Zhang, Junjie Zhang, and Prof. Song? Yeah, thank you.
So I fully agree. I would like to have some comment from Sixian.
I think congratulations for really success to treating this patient who has the very worst condition before the procedure. I think that Zhang has already mentioned that the tiny intervention is very important, given that those patients are already, cardiogenic shock and even be put on the mechanic circulation. But even that, the patient still have very congestion lung. And if that we are not able to do tiny intervention, the patient might encounter, further, system infection, something else, and then we're not able to get rid of the worst condition. So I think that is really fantastic. But I only have one question: is that if we put on the ECMO support, so far I don't know the answer, and we would reduce the venous return. So therefore, after mitral tear procedure, if the mean gradient of 5, I just wonder, because we still have ECMO to reduce the airway pressure, airway volume, but after the procedure, if we have 5 immediate after the procedure, if we remove the ECMO, will we have encounter increase in mean pressure gradient? I don't know the answer. And also at that time, the airway pressure might not be sensitive to as a guidance for the procedure. So I think basically the procedure is really fantastic, but I don't know the gradient issue, whether if we move the ECMO, whether we would encounter. So maybe at that time, the measure of the residual mitral valve area could be one of the assets. But in that situation, I think try to abolish all MR is the first test to to bring the patient get rid of the condition. Maybe patient can get at least to have less than 2+, and maybe patient can survive to if they need further procedure after that is the most important. We get patients survive.
Thank you very much for Sixian's comment. Actually, I think for the prime tier procedure for papillary muscle, still I think part of patient will finally transform mitral valve replacement, but we get to the times. So from this bridge therapy, so I think the time has been limited. We have to go forward. So next speaker is Professor Wang Shouzhen from Fuai Hospital. So then I think we'll introduce the pure ultrasound guided mitral TEER procedure, the Fuai Hospital experience and data. So then it's your turn.
Okay, thank you, Professor Zhang.
Yeah.
Okay.
Professor Shouzhen,
Good
I
morning.
think we all familiar. He is now the vice chief of the cardiovascular structural heart disease department of Fuai Hospital. He is also the younger leadership in structural heart disease, not only in surgical but also in percutaneous for structural heart disease, and do a lot of clinical studies. So let's welcome Shouzhen.
Thank you, Professor Zhang. Good morning, everyone. So it's my pleasure to take part in this conference, and I will give a brief introduction about the TEER procedure with only echo guidance and some data from our center. And I will show my screen, share my screen. Oh, sorry. I need to turn off the Zoom app and to restart this app. Sorry.
Yeah, we were waiting for you. Yeah.
Okay.
So, Prof. Sixian, Prof. So we can use this time to discuss the small question you just mentioned. So immediately after the procedure, the pressure gradient is maybe 5 millimeters mercury. But I just mentioned for some patients, after 3 months later, the pressure gradient deeply decreased, maybe because of the remodeling of the LV and LA. And a papillary muscle rupture is an acute statement. And after time, the LV dilated, so can also cause deeply decrease of the pressure gradient. Is that right? Yeah.
Maybe. Thank you.
Oh, sorry, Dr. Zhang, I interrupted you.
Okay, go ahead.
Okay,
Go ahead.
go
Go ahead.
Okay, I will share some outcomes and of the TEER procedure with only echo guidance. So first of all, I want to explain why we do this procedure with only echo guidance, because some patients are sensitive to X-ray, especially some elder patients or some patients with precancerous disease. So we need to avoid their risk of cancer. The second is that for some severe patients, especially the patients in ICU or with ECMO, maybe we can have a more rapid response to the treatment demand. So we do not need to transfer the patients to the cancer lab or the hybrid option room. And the third reason is that we need to protect ourselves, especially the echo doctors. We all know that the echo doctors are more close to the X-ray machine. So I think the most important reason that we can do this procedure with only echo guidance is that the echo is the main imaging modality for TEER procedure, even though even in the traditional procedure, you know, I mean, with the echo and the X-ray guidance together. So I think this is very important. And our team, actually speaking, has, I think, very rich experiences with the echo-guided procedure. Now we can complete the device closure for congenital heart disease and some balloon valvular plasty or even transcatheter valve replacement procedure with only echo guidance. And how to complete the TEER procedure with only echo guidance, I think only some steps we need to be careful. First is that because we cannot observe the whole process of inserting the guide wire from the femoral vein to the right atrium, so we need to very careful to avoid the vein damage. So we must use a soft guide wire and insert this guide wire from the femoral vein. And we must see or must observe that the tip of the guide wire has passed through the right atrium and inserted into the superior cover. So it's very important. We always use the bicaval view to show this procedure. And the second tip is that how to insert the super stiff wire into the left superior pulmonary vein. We always, or we prefer to use bicommutator view or short axis view to show the left superior pulmonary vein and the LAA. So after the puncture, after the septum puncture, we insert the guide wire with the J-tip and to rotate the puncture catheter clockwise, and then insert the guide wire, the J-tip guide wire into the left superior pulmonary vein, and then inserted the puncture catheter and keep the outer sheath of the catheter in the left superior pulmonary vein. And then we can insert the super stiff wire. So we can avoid use the super stiff wire to find where is the left superior pulmonary vein. And if we cannot insert the J-tip wire into the left superior pulmonary vein, we also can use the some guide wire, super stiff guide wire with some circles on its tip to, so this can avoid to insert the wire into the left superior pulmonary vein. And the third is how to complete the straddle step under echo, only echo guidance. We all know that under X-ray, we can see these markers very clearly, but under echo guidance, we cannot see them. So how to complete the straddle step? We can only estimate this relationship by observing the SGC and CDS relationship outside the body. And if we use some new devices from China, they add some markers on the CDS to indicate the straddle step. And the fourth is how to make the trajectory adjustment and only echo guidance. We all know that the 2D echo cannot show the whole trajectory. So we recommend to use the 3D view to show the trajectory of the clip. So I think at the 3D view, it's very similar to the X-ray, so it's very directly. And then I will share some outcomes of our center. This is a retrospective study. It it reviewed the patients from January 2021 and to May 2024. In totally, 194 patients with MR received the TEER procedure, and among them, 113 patients underwent the TEER procedure with only echo guidance, and 81 patients underwent TEER procedure with echo and X-ray together. And this is the baseline characteristics. So the mean age of the total, all the patients is 17 years old. And in the echo guidance group, 88 patients had the grade 4 MR, and 81 patients had the degenerative MR. And in the co-guidance group, 56 patients had the grade 4 MR, and 53 patients had the degenerative MR. So let's see some results of the perioperative. We can see that in the echo guidance group, 43 patients used 2 clips, and 66 in the co-guidance group used 2 clips. And for the 30 days MAES and the technical success, device success, and the procedural success, we can see there's no difference between the 2 groups. And in the echo guidance group, the MAE incidence of MAE is 5%, and the technical success is 97%, and the device success incidence is 89%, and the procedural success is 88%. So we can also find both the significant MR reduction and improvement in the New York Heart Association class in both of these 2 groups. And we also can find that there's no difference for the 1-year freedom from all-cause mortality or composite of the all-cause mortality and heart failure hospitalization between these 2 groups. And although we can find that the TEER procedure with only echo guidance is safe and effective from the retrospective study, but we need to give more and stronger evidence. So we designed a randomized control study to demonstrate that the TEER guidance with solely echo guidance is safe and effective. Yes, this is a multi-site RCT in China, and it also contains a single-arm cohort to assess the outcomes of this the TEER procedure with only echo guidance for the patients who are constricted to the radiation. Now, in 7 centers, in totally 142 patients have been enrolled in this study. And then I will share some published data for the first enrolled 142 patients. We can see from this data, we can see that for the effective endpoints, we can find that when considering the technique success, device success, and the procedural success, we cannot find any difference between the echo group or the co-guidance group. But we can see that for the co-guidance group, the mean time for the fluoroscopy duration is 5 minutes, and the radiation dose is the 158 m green. And for the procedure duration, there's no difference between the two groups. And also, when we considering the safety endpoints, we can see that we analyze the instance of AE, that there we can show there's no difference between the two groups. So in conclusion, that TEER with only echo guidance can avoid radiation damage for both the doctors and the patients. And the respective study from our center had shown that the TEER procedure with only echo guidance was safe and effective. But we think that the RCT now we having will give the more evidence to show that the TEER procedure with only echo guidance is safe and effective. Okay, thank you. Thank you very much.
Thank you, Susan, for your excellent presentation, introduction of pure echo-guided TEER procedures from the Fuwai Hospital from Professor Pan Xiangping. I think it's an innovation. So according to your retrospective study, compared with combined guidance, echo guidance, I think is non-inferior to co-registration. And also you can see in terms of procedure device successful, actually it's equal. And also we noticed in terms of the hospitalization time, actually echo guidance was shorter than the co-registration guidance. And I think this technique we should also follow and promotion. So would you introduce some key point about the echo guidance TEER procedure? So the key points introduction for the audience on the online.
Thank you. Thank you for the questions from the Professor Zhang. I think if a team want to do this procedure with only echo guidance, I think the team should be very familiar with the procedure with the echo and the X-ray guidance together. So the next step that the team can simplifies this procedure with only echo guidance. And I have showed some teams for how to do this procedure with only echo guidance. I think most important is that we need to establish the pathway or the circle or the railway with only echo guidance. Very important is to avoid the damage in the pathway. Very important, the femoral vein and the inferior cave. So I think the very important that we need to avoid the damage to these vessels. And another thing is that how to do the straddle step. We all know that the straddle step is very important for the trajectory adjustment, or it's very important. So how to make the straddle step with only echo guidance. For the mitral clip MC device system, so because there's no markers on the CDS, so we can only estimate this step by observing the steerable guiding catheter and the delivery catheter, by observing this catheter's relationship outside the body. But when we have some new devices like Dragonfly or X-Clip, there's some markers on the CDS to indicate whether we have the right relationship between the CDS and the SDC. So I think this with the new devices, it will make this procedure more easier with only echo guidance.
Thank you. Thank you. Excellent, Professor Wang, for your introduction of the detailed tips. So I think let's have to go forward. So please, Professor Suda, introduce next speaker.
So yeah, for the matter of time, we're gonna introduce the next speakers. Professor Pan from Zhongshan Hospital, and a very famous professor in structural heart disease in China. So he will bring us. He designed a novel device of valve clamp. Now, valve clamp is the first approval tier system in China, and he using a very specialized transit approach and to handle a lot of challenging anatomy. So our speaker was Professor Pan Wenzhi. So majority of the audience should be very familiar with Professor Pan. So I will try to I won't try to introduce more. So welcome, Professor Pan, to share your slides.
Okay. Thanks to Professor Zhu and Junjie, and also all the friends. It's my pleasure to show the topics about the vacuum. Okay, I will give some update of this device. I think most of my friends maybe know some about this, but today I will give some updates. Okay. Can you see my screen?
Yes, we can see the screen. Now we can see the slides.
Okay. And thanks again for Jinjie to organize this meeting. My topic is about the vacuum. First, I will introduce some background about the MR in China. I think this is the study in Vegas in our hospital. We found the prevalence of MR frequent in patients over 60 years. The prevalence of severe MR in our hospital is is up to 2 points. Okay. And also the severe MR is prevalent of the patient with low LEF and enlarged left ventricle is up to 1/3 patient have MR in this patient. But the MR is lots of them did not accept effective treatment by surgery because the patient have high risk or old ages. In 2012, the professor do the first master clip in China in the OCC conference, and I will follow him to do these cases. And beyond these cases, I was greatly shocked by the procedure and feel like this is a very wonderful and revolutionary technique. But after performing several cases, I found that there are some problems. Because in that time, the microclips is G1. It's very difficult to capture the lips. And also the echo did not have, at that time did not have the 3D echo. So we feel it's very difficult to do this procedure. I remember in one case we do 4 hours to capture one to implant one clip. So we hear this is very difficult procedure, and more important, and there are no commercially device in China, and the price is very high, very expensive for Chinese patients. So at that time, Jingle request our team to develop the device that is easier to operate and suitable for Chinese national condition. And most important, to be cheaper to meet our huge demands of domestic patients. So at that time, we start to develop the tier system. But until 22, the Mitral was approved. So before that, we did not have any tier device. So we to develop the tier system in our team. And in 2018, we do the first human cases, and this is reported by many webs, and also include the people daily this. So we publish serious papers for this technology, and include the precise model experiments, also the film, and also the large scale study. The well claim this is a normal user-friendly transfer mitral repair system. It has some advantages. So the first is easier to operate because the transapical route is short and straight, and easier to master this technique, and easier to claim the position through the one transmission movement, and it has a larger space to capture the leaves. And most important, it can guide by echo only, and no S-rays is needed. We in all our cases, we did not use the S-ray to guide the procedures. And this image shows why the vacuum have larger capture range and easy to capture flare leaves. For patients have large flare, the large flare is difficult to capture the leaves because the flare gap is large. But for the vacuum, in these cases, it's easy to capture the leaves. So it's more easy for these types of patients. And also the vacuum has has the closed ring, so he may make stronger clamping, and it can catch much leaflets. In some cases, we can catch the leaflets. The leaflet length can up to 20 millimeter. So it keeps more leaflets, and then can make wide cooperation. So in most of the cases, we just can use one clamp to treat the patient effectively. No need to implant 2 or more clamps. And for the first human study, we can see compare our device. It has less capture time. It's just 26 millimeters. And now in some cases, for some operator, it just use 5 minutes to do the cases. And we also to test the damage of the lips use this system, because the gripper of the clamps is blank, so it has less damage to the web. You can see this is the pig's heart. We use the device. Okay, we do text to do the pull test, and after this, we found no damage to the leaflets. So it has less damage to the leaflets. So and then we implement our current. So we do the test for the claimed damage in the animal and showed it had less damage to the lips because it has blunt steps in the liver. So I will show some cases of very claim. You can see this one cases. This case has large anterior deep prolapse. You can see the circulation range is very wide. But for these cases, we just implant one clamp, and the circulation is diminishes. So it has larger capture length. So most time we just use one clips can have a very effective effects. And also you can see this a large flare and very larger regulation. And we also one clamp implant and the MI is diminished. So the advantage of this device is it can catch more leaflets. So at most time, it just one clamp can diminish the MR. No two clips is needed. And also can see this is have wide range regulation. Also, just use white clamp and MR is diminished. So the advantages of this device is has a longer leafless cooperation. So and in many cases, just one clip is needed it has a better efficiency. And this is the commercial case is the C2 prolapse cases. And also for these cases, we implant one clips, and it has also just trivial residual MR. So we to see the 1 year results of the pre-market multi-center study is reported by Hassan, and this is conducted in 11 hospitals in China from 2019 to 2020. And the main outcomes is freedom of the composite endpoints of death and surgery of valve dysfunction and MR less than 3 grades at 12 months. We can see the acute procedural success rate is 97%, and for the last 52%, it has a higher procedure. You can to the 96 success rate in 1 year because the operator had more experience. And this is the 1 year follow up. 98% had MR less than 2 grades in 1 year. And you can see the operation, catheter operation time is just 19 minutes. And for the late group, the operation time is reduced again. Only just follow it. And 88 patients just implant one device. Just one device is needed for most of the patients. And also we do the vacuum for FMR to do the study, and this is the 12 patient, 5 AFR, 7 is VAMR patient, and we found the device association is 100%, and the 3 months follow-ups, all the patients have the MR less than 2 grades. And this another study for the AFMR and VAFMR patient, and again the MR to less to 2 grades at 12 months is also 100%. That's all the patients has the MR less than 2 grades in 12 months. Not only for the AFM patient, also for the VSR patient, to have good results. And these 2 year follow-up for the back clamp in our hospital, and we found that venture is reversed, and LEF is also is improved, and pulmonary artery pressure also is reduced for 2 years follow-up, and we found the MR is stable, and just 2 patients have MR 2 3 grades in the 2 years follow-up, and NI SA function is improved through the 2 year follow-up, and maybe we have some current worry about the apical damage, but we use the echo, the Doppler, to assess the apical image damage. We found in 3 days there is a slight decrease for the apical systole function, but at the 2 years follow-up, this is improved. No different to baseline levels. That's in 2 years follow-up, the apical damage is no seen. So no damage to the apical systolation was seen in at the 2 year follow-up. And use this innovative system, we some doctors invent some new procedure for procedure, such as they use the J-wave together with the vacuum and do the one-stop power and tear for the mitral regurgitation and atrial regurgitation. And also they do the vacuum combined with the mid CABG to cure the patient with the coronary heart disease associated with the MR. Also, they do the heart tear and the transapical the septal myocardial echoing for the patient with HOMC and MR. Also, to use vacuum to for the patient have HOMC and MAR. Because the vacuum has larger larger lip catcher, so I think it's more suitable for the HLM patient and MR because it can catch more leaflets, so it can reduce the HOMC more effectively. Also, the vacuum has go to the overseas. It has marketed in Malaysia, Thailand, Colombia, Singapore, and Vietnam. And many countries has do this has used this device for treating the patient with MR. So I will give a summary. There's a huge market for the MR in China, and a huge need for development of MR in MR intervention device. The development of MR device in China started later in the world, but and vacuum is the first domestic device approved by CFDMA, and this device adheres to the design of more clapping and simple operation, and have some unique advantages in line with China's nation communication, and has been recognized and verified in politics. So thanks for the attention.
Thank you very much, Professor Pan. Sorry, I'm outside. It's heavily raining. Sorry for your very great for your introduction. Very novel Chinese devices, care devices, and a very good result. And a lot of countries using Chinese devices to treat the patients. Thank you very much. So
Thank you, Jun.
any questions from the audience? Okay, so for the sake of time,
yeah, okay.
yeah. So for the sake of time, so we move forward to the
俊杰
next section because we
张主任他那个张院长他的麦没开。
yeah, I think he's
Professor
he's
Zhuda,
on the,
I have one question for
okay,
Wenshi.
okay.
Okay.
I think it's the first innovation about the tier device from China, and also it's from the Apex compared with conventional from the septal puncture. So I think the most advantage just as one's introduction actually coaxial. I think it's better achieved and also can use valve clamp grasping the larger and the longer leaflet. So what I concern is for DMR, I think valve clamp has advantage, but for FMR, so do you have a randomized study comparing conventional something like the metric clip versus valve clamp? So I think this is the first question. Another question is in terms, I think this device is not only approved in mainland China, but also approved in overseas market, just like one paper, one belt and one road countries. So my question is because it's should perform with trans apex. So for this procedure should be performed in hybrid room. And also what's the profile of these sheaths combined compared with the metro clip 24 French? How about valve clamp, the sheath profiles? So thank you.
Okay, thank you, Professor Zhang. I think you give us a very wonderful advice. I think for Vecna, I have seen, I have see this device has some advantages in AFMR patient. Maybe in AFMR patient, I think to catch more and safety, it can make more lip leg cooperation. So and maybe have good good effects. So I think maybe I can do randomized trial to confirm my concepts. Uh, and for your second question, I think the deliver cyst is 16 French. It's 16 French, and we introduced the device to overseas, and they do the by the surgery. No for the internal doctors. It's for surgery. No for the cardiologists in the Southeast Asia, and they are popular by the surgery in Southeast Asia because they can quickly master the technology. Also, is more cheaper. So and we make more some promotion in that country. Okay. And it can no hybrid room is needed. It can just do in the common surgery room. Common surgery is needed for the technology because no SJ is needed. Okay.
Yes, it's a purified echo guided tier procedure for valve clamp system. Yeah, that's very great.
Thank you first too.
Okay, can we move to the next section, the last section?
Sure,
Okay.
sure. Go ahead.
So go ahead.
Okay.
Thank you again.
So we going to the next section was actually robotic assisted tier procedure. It's a very novel Chinese technology provided by Professor Chen from Xiamen Cardiovascular Hospital. And Professor Chen was the deputy director of the Structural Heart Center of Xiamen Hospital. He's very famous in doing a lot of creative stuff. So he will bring us very interesting topic on robotic tier systems. Welcome, Professor Chen. Yeah.
Thank you, Dr. Zhu's introduction, and thank you, Professor Junjie Zhang's invitations. Let me share the screen. Okay. Can you see the screen?
Yes.
Okay. I'm Dr. Shan Chen from Xiamen Cardiovascular Hospitals. Today, on behalf of Professor Wang Yan, I will provide a brief introduction to our robotic systems and its applications in mitral TIA procedures based on our experience and data. As we know, TIA has been established an active true surgeries for the treatments of high-risk MR. Several guidelines and experts cancers have proposed standardized protocols for the TIA procedures. Robotic systems are well suited for performing such standardized procedures, offering the advantage of the remote and stable controls of the clipping device. The surgical path robot systems was designed and developed in China. Follows with model testing and animal studies. The first robot assisted mitral TIA using domestic device was successfully performed at Xiamen Cardiovascular Hospitals in late 2023. As shown in this message, the systems complies with main components, the instrument controls platforms. Also, I like to call it a system app, and the host trolleys and the daughter's consoles. The robotics here we can observe three adaptive functions modules compatible with the mitral G4 system. By manipulating the modules, we can control the guiding caster, clip delivery system, and clip itself. This is a controls panels with the which allows device manipulations with either a touch screens interface or a joystick and buttons configurations. Each components of the systems corresponds to specific functions modules. So this is videos for our bench test. We can see we loading a mitral G4 system here, and we can advance the CDS and medians can more plus the gaseous and medians the CDS as we matches and open the clip R and continues to advance the up and clip R and down also by the console and close the up. Also, this we can manipulate the remote outside the cath lab. And today we have already performed first robot assistant TIA procedures, 5 cases, and we have validated the system's stable and consistent movements throughout these procedures. The interface is user-friendly, which we believe facilitates a shorter learning curve. Importantly, the system enables real-time remote control, offering significant benefits for online trainings and remote surgical assistance. Foremost, it significantly reduces radiation exposures for medical things. But nowadays, we still exceptions of the anesthesiologist and echo guy. But I think foremost maybe the AI guys robotics for echo for TE was foremost developments in the future. And now I would like to present the baseline criteria of the participants. In our physics trials, the mean age of the participants was 76.2 years, with 69% being female. 4 out of the 5 patients presented with New York HA's function class from 3 to 4. Baseline anti-proBNP levels was notably elevated. The images criteria please procedure images reveals average of left ventricles ejections of 58.4%. All patients have 4 degrees mitral regulations, including 3 with deteriorations mitral regulation and 2 with functions mitral regulations. The average posterior sleeve length was about 17 millimeters, and the mitral valve areas shows 5.5 square centimeters. And the procedural detail, the procedural times was somewhat extended. Particularly in the first 2 cases, maybe you know this is still a first in main clinical trials, and 3 patients received 1 clip, while 2 patients was implanted 2 clips. There was no intra-procedure deaths. All patients achieved moderate or less mitral regurgitations post-procedures, with 80% demonstrate mild or trace MR. At the 30 days follow-ups, no patients had died. Most patients shows significant improvements in cardiac functions, and the reductions in mitral regurgitations remains stable. The New York HA function class, the slides illustrates the New York HA function class as baseline, and at the 3-day follow-up, demonstrating significant improvements. Also, this is the data of our multi-centers first immense feasible status. We together with Fulbright Hospital of Dr. Zhu and the team of Dr. Pan Xiangbing, and we have first in main 9 cases. And we also can see the significant MR reductions and New York HA class improvement at the 1 month follow-up. Now, finally, I will show first cases with loading the G4 systems. This is 85 years old lady presenting with worsening dyspneas. The New York Heart class shows 3. New Heart class 3. The history is persistent atrial fibrillations, renal insufficiency, and stroke. TTE reveals severe edema, posterior collapse, and with left ventricles and atrials enlarged, and right atrials enlarged, and left ejection shows 61%. T shows P2 plus and ruptures of the codice. The ELA is 0.68 square millimeters, and the VCW is 10 millimeters. The STS score shows more than 10%. We can see the multi views. We can see this is in sensuous regulation from the LVOT views, and this is X-plane view, and we can see the commercial view collapse from the A2P2, and posterior leaflet collapse is not very high, and but severe and essential regulation. This is 3D views. We can see the flaps. We measure it's more than 10 centimeters. Maybe it's a 2-click case. Maybe well, after we to clips the height of the flaps, the silver flaps, the positions. Maybe we see the result after first clip. So after we punch the septal actual septal, we need to measure the height of the guide shift. More than the height is more than 4.28. And we use the robust arm assist the T procedures. We can see the arm is already inside the left edges and very close to the mitral valve. And if the clip is too little, we can use a clip arm to control the system from lateral to the medial. And it's the two aortic heart. We can use a plus to reduce the aortic heart. So this is the first clip, and we can adjust the orientations in the edges. So this first the clip we can from the lobar arm system, we open the arm and see the clip, which is the anterior and which is the posterior. So also we can advance close the valve to the ventricle, and we also can adjust again in the ventricles to make a good orientation. So we can see the catch the anterior and posterior enough. We can see the bouncing, but maybe the posteriors cannot catch enough, and we can also to optimize the posterior catch. So after we catch release the first clip, and we can still use the reduce the regulations at the first clip, the lateral side. So we need to optimize the MR to reduce the maybe this 1 or 2 plus MR to we optimize with another clip from the lateral. So after second clip release, we can see the clip is very stable, and we already catch enough posteriors and anteriors, and little tension from posteriors. And this is the final results of 3D view. We can see only maybe 1 plus reduced MR from the median. So, but the laterals of the MR is disappears, and the T-split is very the T-split is very clearly. So finally, the reported case and for the first time, we are domestic this first in main procedure the robotic assist arm guides the TE domestic feasibilities of the lobar assistant TE procedures. We need to understanding the anatomies and participate peers of experience and guidelines of echo are still the basis. Follows clinical tests are required on the whether the effective safeties and complexities of the system. So we already ongoing the RCT research, including 4 Chinese centers and already to finish the 15 cases in the RCT RTT trial in the RCT clinical trials, and potential applications of the 3G plus robotic system platforms is tricuspid and aortic valve interventions. AI integrates techniques, multi-sensors deployments or never implement will promote the intelligence treatments of structural heart disease. Oh, that's all. Thank you.
Okay, thank you for Dr. Chen. Any question from the audience? So it's a very interesting technology, but it's still not widely used. It's a very user-friendly robotic system, and then manipulating the devices to perform the TEER procedure with more accuracy and stabilities. And any question from the audience? It's a very interesting topic.
Congratulations. I think Dr. Chen Xiang, I think your center and also the Wuhan Hospital, Professor Pan Xiangbing and Professor Zhu Da contribute a lot for this domestic. I think it's the first robot assistant TEER procedures. I think so far now in China, I think we do a lot of innovation, not only in technology, but also in device, contribute to the global field of the structural heart disease interventions. And I also warmly thanks today's our co-chairman, Professor Zhu Da, and also 5 distinguished speakers, including Professor Song Sixian. So Sixian, do you have some comment about the robotic TEER procedure?
Yeah.
I don't have.
Okay. So
Okay.
Professor Zhu Da, please go ahead, give us closing remarks of this fantastic session.
Okay, thank you, Professor Zhang. Thank you. So it's very honored to be here today to share with 5 lectures around the new technologies and some kind of progression into transcatheter TEER-to-TEER procedures. I think in the future, China, we have a lot of new devices. We have even new robotic systems, and we are providing more evidence and to share with the world. Thank you very much. Thank you for Professor Zhang, to organizations. Thank you for everyone joining the session.
Thank you.
Okay.
Thank you. Bye bye. Looking
Okay,
forward to
bye.
meeting in
Bye.
person. Bye. Bye.
Bye.